Thank you, Gartson, for that wonderful introduction. I do have a tendency to have a very low voice, so if you can't hear me, raise your hand so I can raise my voice, okay? So we're here to talk about newly diagnosed epilepsy. And so the first thing I want you guys to know, when the doctor has told you have epilepsy or that your child has epilepsy, or if your family member has epilepsy, you're not alone already. Tell yourself, I'm not alone. The feeling can be a bit isolating. You can feel alone. You can feel like there's no one else who will understand what we're going through. You can feel there's not a lot of people you can reach out to. But just look at this event today. So the first thing I want everyone to know is you're not alone. Some stats to back that up. 1 in 26 people have epilepsy. Let's think about that a little bit. 1 in 26. I heard an interesting statistics recently. So if you take MS, everyone knows multiple sclerosis, right? You're familiar with MS, autism, Parkinson's, and cerebral palsy. Everyone here are familiar with those diagnoses, right? If you take all 4 of those and add them together, more patients have epilepsy, more people have epilepsy than all those 4 conditions added together. That's pretty significant, okay? 1 in 26, so you're not alone. And so don't feel alone, don't feel isolated. There's a wealth of information out there. And so talk to your physician, talk to your community, and see if and find support groups. So find events like this so you can come and learn more about it, gain information, so you can be the best advocate for yourself, the best advocate for your child, and the best advocate for your family member. Okay? So knowledge is power. And just know that you're not alone. We're here to help you. Okay? So that's the first thing I want to emphasize, that you're not alone. Okay? Next thing is, so yes, I have a diagnosis. What kind of information should I ask my physician when we sit down and say your child has epilepsy? Okay? So typically, the first thing I always tell my families is what type of epilepsy, what kind of seizures does your child have? Okay. So what kind of seizures do I have? What kind of seizures does my child have? Did my child have generalized seizures or focal seizures? What's the difference? Generalized seizures is when seizures occur in the entire brain at the same time. Focal seizures occur when seizures come from one area of the brain, which may or might not spread. Okay, so that's one information you should kind of in your notebook. A lot of my families start with a notebook. They have a little epilepsy journey notebook that they start to jot all these down, because it's hard to remember everything. And when you're first diagnosed, there's a shock. There's like a worry. There's a lot of anxiety with it. All understandable. Everyone goes through all that. So it's always a good idea to jot things down. So one of the first information you should jot down is, what kind of seizures does my child have? Does my child have focal seizures or generalized seizures? And a lot of times the doctor may know based on how you've described the seizures, and a lot of times they may not know. And if they don't know, then ask them, well, what kind of tests can we do so we can know whether my child has focal seizures or generalized seizures? Okay? So based on history, how do we know in the office what you tell us, how you describe the seizures to us? And this is where I always, honestly tell my parents, this is where I get a little OCD and I ask for a lot of details. What's the first thing that you see? Do you see your child stiffening all over at the same time, all at once, and then jerking? Or does your child stare and then have some other movements? What is the sequence of the symptoms that you see during the seizure as it evolves? Okay, that's very helpful. Because as I was telling other people, that as the family, as the mom, as the caretakers describing the seizure to me, I'm already localizing in my mind, where is the seizure potentially coming from? Which part of the brain is the seizure coming from? And that's important, because I'm going to decide, as I'm listening to you, I'm also going, okay, this sounds like a focal seizure coming from the temporal lobe, therefore these are the meds that I will use. So that's what's going through my mind as I'm listening to you describe the seizure. So this description of the seizures is very, very helpful. And it helps guide us a lot in terms of management and treatment and workup as well. Okay, so description of the seizures lets us know if the child has focal seizures or generalized seizures. Okay, then the next thing is, well, what's the cause for my child's epilepsy? Alrighty, and that's always helpful, and it helps in terms of prognosis as well. Depending on the cause, a lot of parents ask me, well, is my child ever going to outgrow the epilepsy? It depends on what the cause is. Alrighty, there's some causes where I'm like, okay, this is actually a very good outlook. And other times, like, okay, let's think about this in stages here. And so the cause, or the medical term called etiology for your epilepsy, helps us a lot in terms of prognosis and also what to expect over the years to come. Okay? Then the next question is, like, well, what are the typical causes? The typical causes fall into a handful of categories. The first is genetic. If your child has a genetic mutation that has been reported to be associated with seizures, that's one common cause. The second is structural, the bending and what the brain looks like, the bending and the folding of the brain. If there's an area of the brain that did not form quite right, then that's going to be a cause for your epilepsy, okay? So structural is the second big category. The third is metabolic, and this one is a little harder to explain, so I try to say it in terms of energy, right? Your body, when your body eats food, carbs, fat, protein, it goes through several different pathways to break it down to make energy source. When there's a problem in any of those pathways, your body's not able to make enough energy. And when there's not able to make enough energy, you can have a seizure, or epilepsy is part of the symptom from that. Okay? So metabolic is the third big category for etiologies of epilepsy. The fourth is infectious. For example, if you were healthy but then you have encephalitis, you got infected with a virus or a bacteria, and you get encephalitis, that can be a cause for your epilepsy. And depending on how bad your seizures were during that infection, it can cause seizures later on in life. So infection is another big category. Another big category, more so in the adults rather than children, is autoimmune, where your body, while it's trying to fight some infection or fight off certain things, they also make proteins that attack parts of the brain that can contribute to seizures. So autoimmune is another big category. More so in adults. We see that more in adults than with kids, okay? And the last is idiopathic, meaning we don't know, alrighty? We did all the tests, we did the history, we get the birth history, the past medical history, we get a detailed history about your child, we do all the workup, and at the end, everything is normal. And in that case, we typically lump it into what's called idiopathic. Okay, so that's the next big piece of information you should ask your doctor is, okay, so I know my child has focal seizures or generalized seizures, and based on the workup, what is the etiology? Alrighty, and so that's where you can start, and that's a good place to start. The next step is typically management, right? What is the typical management? What are you going to recommend for my child? What are you going to recommend for my loved one? And when you talk about management, like I said, it depends on your child. It depends on my patient. A lot of things play into it. One of it is what type of seizures, right? As I was saying, as I'm listening to the seizure description, in my mind I'm already localizing where is it coming from the brain, and these are the meds I know are good for these type of seizures, alrighty? Typically we would start with medications. So in terms of treatment for epilepsy, there's four big main categories of treatment modalities. The first big category is meds, anti-epileptic drugs, AEDs. You'll hear us talk about it already. So meds is one big category. The second category is dietary, which is the ketogenic diet. And there's some talks here today about the ketogenic diet and variations of the theme. There's keto diet, modified Atkins diet, and low glycemic index diet. So dietary therapies is a second big category for treatment for epilepsy. The third category is devices or neural stimulation, where there is a device that's implanted in your body, kind of like a pacemaker, connected to the brain and sends signals or impulses to prevent seizures. Okay, so that's a broad category of neural stimulation. And then the last category is epilepsy surgery. Alrighty, so those are the big four main categories of treatment modalities that's been proven through research to help with seizure control and control seizures. Okay. Then prognosis, like, well, will my child outgrow it? Okay, how long will my child be on medications for? That, in terms of will the child outgrow it, depends on the cause. And we may not be able to answer that question within the first clinic visit. It kind of takes some time for us to get to know your child. Like I always tell my family, every child has their own story. Every child has their own epilepsy story. And please give me time and work with me so I can understand your child's epilepsy story and can give you up-to-date information, up-to-date answers as I get to know your child, as the child grows up. Alrighty, so prognosis depends on what's caused, depends on the etiology. That's why as advocates, sometimes we may forget. And so as advocates for your child and your loved ones, say, what's the cause for my child? It's like, oh, okay, let's talk about this some more. Okay. And then, and so in terms of treatment, how long does a child stay treated for? A patient stays on medications. Typically, the rule of thumb is around 22 years. Alrighty. When you start a medication and you're seizure-free for 2 years, then we're going to talk about maybe you've outgrown your medication or your epilepsy, and we can start weaning you off medication. So in terms of length of treatment, it varies from child to child, but on average, around 2 years, seizure-free. So then the clock starts when the last seizure was. For example, you're seizure-free for 6 months, and then you have a breakthrough seizure. The 2-year clock starts again. Okay, and then so the 2-year clock starts when the last seizure occurred. Alrighty. So that's briefly in a nutshell. I know this is a talk to talk about newly diagnosed in terms of what to do, what information to get and ask of your physicians when you first get diagnosed. But I think the majority, the rest of the time, will be open forum for Q&A, for questions that you guys may have, and then that can spur up some more talks and more answers, and I can expand on that as the session goes on. But to review, don't feel alone. You're not alone. A lot of patients have epilepsy. Number 2, ask your doctor, what type of seizures do I have? What type of seizures does my child have? Focal seizures or generalized seizures? And if the doctor says, well, I don't know, well, then what kind of tests can you do so we do know? And the type of test we typically rely on to help answer that question is an EEG. Okay? What is an EEG? It's a bunch of stickers glued to your head, and it records electrical activity in the brain. Okay? And it detects normal activity and any abnormal activity. And a lot of times I tell my parents, the EEG gives us 2 information. Number 1, background, and number 2, epilepsy risk, epilepsy abnormalities. Background, what's background? Background's basically how fast is the brain processing everything, right? If I were to do an EEG on everyone in here, there's going to be like normal background because you're sitting here listening to me and understanding what I'm saying, alrighty? So the background is how fast is your brain processing information in your environment, okay? So that's one aspect. The second aspect is abnormalities that says, okay, if I see these abnormalities, this patient is high risk for seizure recurrence, okay? And that's what I mean, is abnormalities, when we say abnormalities. Are these abnormalities present or not? And if they're present, that means this patient is at high risk for having seizures, recurrent seizures. And if they were to have seizures, where would they come from? And that's where the abnormalities are. So I see abnormalities and say, okay, where are these coming from? These abnormalities are present in the entire brain at the same time, which is called generalized abnormalities. So patients with generalized abnormalities will have generalized seizures. If I see abnormalities mostly in the frontal region, I predict patients probably will have seizures coming from the frontal region. So these epileptiform abnormalities, we call them, or epileptiform discharges, if you read our reports, are abnormalities that tell us this patient's at risk for having seizures. And if so, high likelihood the seizures will come from this region, okay? And sometimes you get a routine EEG for 30 minutes or so in the outpatient and it's normal. I'm like, okay, we're up next, right? We can still do another test called a long-term video EEG monitoring, where you get admitted to an inpatient epilepsy monitoring unit, and we hook you up again to the EEG, and it runs for the entirety of your stay, capturing information the entire time. We can see what your brain waves are doing, what your brain activity is doing during awake and sleep and drowsy and during the different stages of sleep. And also when you have a seizure, where is it coming from? Okay, so in the monitoring unit, a lot of times in the clinic, I listen to the story. I'm like, I have a hypothesis that your child's seizure is coming from this area of the brain. But I want to confirm it, right? I really want to know for sure that this is where it's coming from. And I think it will help a lot in terms of the management and and your journey moving forward and your management roadmap. And so we'll admit you to the hospital, into our epilepsy monitoring unit. There are several hospitals that have it, where we try to capture seizures and see when your child or when the patient has a seizure, where is it coming from in the brain? Okay. Now, a lot of parents ask, well, does everyone need it? Well, it depends. Okay. There's a lot of nuance. It kind of depends. Some patients, when I see the history and I get to know your child, I'm like, we don't need it to go there quite yet. Based on the routine EEG, based on what you're telling me, based on the history, let's start medications and monitor you. Every now and then, I'm like, okay, actually, I do need that study to better understand what's going on. A lot of times, if I say, okay, you have a breakthrough seizure, we're increasing meds so fast, and you're at the maximum dose, and we still can't control seizures, that may be another case where I would say, let's bring you into the unit and capture seizures, and we'll see what's going on. So see why aren't these seizures responding as we expect to the medication, because we're increasing it, okay? So that's one diagnostic test that we typically do is an EEG test, whether it's be a short outpatient study for 30 minutes or so, or a longer study. Typically, we do it in the inpatient, but there are some services that do it as an outpatient, where it's called ambulatory EEG, where you come to the hospital, we put the EEG on, you give you a backpack, and you wear it, you go home, continue with your daily activities, and then come back. When do I use one or the other? It depends on the question I'm asking. Alrighty. If it's a question of like, I want to understand and see your child's seizures and know where it's coming from, I probably would like to do it in the hospital, because at that point, my nurses and my technologists can do response testing, meaning, okay, let's do some testing during the seizure to better understand the seizures more. Okay. If the question is more like, I just want to know how often is little Johnny having seizures, or so-and-so is having events only during at school during this time period, that's when I would do an ambulatory EEG study. So depending on what the question is, determines when I would want to use an inpatient study or versus an outpatient ambulatory EEG study. Okay? So EEG is one diagnostic test. Another group of diagnostic tests is neuroimaging. Okay? The most common use is MRI of the brain, a magnetic resonance imaging. I kind of liken to a high-res resolution, right? So you go to the Costco and you see TVs and you have regular res, and now you have high res with 4,000 hertz or whatever, right? And so the MRI is the same way. There's different resolutions to give us different cuts and different details of the brain. And so for patients with epilepsy, we want the highest level of detail in the imaging study to give us a good picture of what the brain looks like. And that's typically called a 3T, a 3 Tesla MRI. It's the high-res MRI. And so if your doctor orders an MRI for your child or for your loved one, ask them, is it going to be a 3T MRI? Because it's the highest resolution that we can get to give us a nice detail of what your child's brain looks like. Okay? And typically we do start there with just an MRI study. CT heads is good to assess for blood. Okay, so if a patient comes to me and say, I'm doing an epilepsy intake, I typically want an MRI because it gives me more information. A CT doesn't give me the information I need to understand the bending and the folding and the structural context of your child's brain, and it's just radiation that I don't think your child should be exposed to. So I order a CT when I'm concerned about bleed or a fracture. Otherwise, I typically prefer an MRI of the brain. Okay? Then there's another group of some lab tests too. When you talk about remember I said one of the causes, genetics and metabolics. In order to work that up, it comes in the form of blood tests. Okay, so to work up to see if the cause of your child's epilepsy is genetic or metabolic, I get blood tests. Sometimes some of the tests can be done via swab, so that makes it easier and not have to have a needle poke. We can do some swab for some genetic testing. And some of the testing for metabolic disorder requires urine testing. Okay, so in terms of labs, we have blood, saliva, and urine tests in terms of when we investigate what's the cause for your child's epilepsy. Okay, and also depending on the history, we may suggest what's called do a lumbar puncture to get some fluids from the brain to test those fluids. Because a lot of times some of the metabolic disorders in the blood, the molecules or the testing that we want to do in the blood, it may not be accurate. And we actually need the fluid that bathes your brain in to test that fluid to see if it has the abnormalities that we are concerned about that can be the cause for your child's epilepsy. It's not every child needs it. We typically do that in a child depending on the history, depending on the level of acuity and whatnot. But that's also another test that some physicians will do called the CSF, or to look at the CSF to see what's the cause for your child's epilepsy. And those are the main categories of diagnostic testing that we do to assess and try to find answers for the cause of your child's epilepsy. Okay, and so that's a quick run through. I'll open the floor now for questions to see. I know I always tell my parents, I gave you a lot of information. I did a lot of talking here. Let's have a little conversation here so you can better be advocates for your family. Yes.
So like you said, after 2 years of being seizure-free, you can maybe
consider
not being on the medication anymore. But then if the seizures come back, do you go back on the same medication? What is that gamble? I feel like because
a very good question. So a lot of times, my patient comes in, it's been seizure-free for 2 years, we're talking about weaning off meds. A lot of times I get an EEG to help because the question is exactly, what are my chances of having seizures off medications? And we kind of use, we use the EEG as a guide. It's not perfect. There's always, nothing's ever 100 or 0%, but it's a guide for us. So before I wean patients off medications, I typically get an EEG. If the EEG is normal, the chances of seizure recurrence off meds is around 20, 25, 30%, okay? If the EEG is abnormal, the chances of seizure recurrences goes up to 50 to 60%. All right, so at that point, we have a conversation in terms of what should be the next step. And a lot of times, because the chance of seizure recurrence is higher if the EEG is abnormal and can have impact on the quality of life, we typically continue meds at that point. Okay, but it's a conversation that we have individually to see what's a good guide. In terms of parents often ask, okay, so EEG is normal, we're weaning off meds, if seizures were to recur, when will it recur? And so there's a few studies, long-term studies that showed the highest time period for seizures to recur during the process of weaning off meds is the first 6 months after you're off meds. The longer you go after that with no seizure recurrence, the lower the chance. Okay. And they can change, absolutely. And so it can change, seizures can change over time, even if you're on the medication. And so that's why it's always a reassess. Do you go back on the same medication? It depends. If the seizure is the same and you did well, you tolerated well, we'll restart the same medication. However, if the seizure is the same, but you said, well, I was on Keppra and I didn't like how it made me feel, then we'll talk about other options as well, okay? Because Keppra worked for one patient for those years, but moving forward, this is what we want to do. Maybe it's not the best medication. Let's think about other choices, okay? So a lot of times we do tend to go back on the same med because it was working, but that's where you speak up and say, actually, is there another choice? Because on that medication, this is how I felt, and I wonder if there's other options for me. And so that's a conversation you can have with your physician. Does that help answer your question? Yeah.
On the EEG studies,
Yeah.
if you have a kid that doesn't have seizures all the time, so they're not that frequent, and you go to the hospital and they're there, and they don't capture any seizures, do you just keep coming back, or do you have something? And they mentioned that one that goes home with you.
Yeah, so if a patient of mine comes into the hospital, we try to wean off meds, sleep deprive, and do other provoking factors to capture events, seizures, and we're not able to, it's good news because it shows you don't have a high seizure burden. But if we still want to answer the question, where are these seizures coming from, an ambulatory EEG is a reasonable next step. A lot of times I ask parents to do a seizure diary. Right? What's in the seizure diary? Like, when did she have a seizure? About what time? If it's an adolescent female, when was your last period? When did the period start and all that? To see if we can map out, see a pattern of when these seizures tend to occur, when your child tends to have seizures. And we try to time the studies around that time period. So a seizure diary is very helpful. There's a app called Seizure Tracker or Seizure Log. That was actually developed by, I just learned this, developed by a parent of a child with epilepsy and wanted to follow seizures and see how different med changes affect the seizure and and the response and whatnot. I want an easier way to do it. So created an app called the Seizure Tracker. And that's where it kind of helps me when my parents come in, some of them come in with a calendar. And I said, when you have the seizure, just mark on the calendar. And when we look at it, we kind of see a pattern, and then we can help kind of gauge and schedule it such that it increases the chances of capturing a seizure. Yeah, very good question. Very good question. Yes.
So if your child has had all this test and nothing showed abnormal, and there's still a panic seizure, then that's step. Is there anything else to do in diagnostically?
Okay. So in terms of diagnostic tests, there's a lot, but there's also limitations too. And depending on the history and a little bit, history and everything, we kind of gauge the diagnostic test to that. Like I said, genetic-wise, there is some blood tests for genetic testing. The ultimate genetic testing is called whole exome sequencing. So let's talk about the different types of genetic testing. All right, we say we do genetic testing for epilepsy. What are the different types of genetic testing? There's three main categories, right? The first one, which is typically what we do, is called a microarray. A microarray is a screening of your genetic library. It picks up any big deletions, any big duplications, any big abnormalities on your child's genome. Okay, so a chromosomal microarray is the first screening test we typically do. The second type is gene panel, epilepsy gene panel. Because of all the research and the abundance of genetic knowledge we have now, we know certain genes that they're mutated will cause epilepsy. And there are certain panels now that consist over 500 to 600 genes that are known to cause epilepsy on this gene panel. So that's the second type of genetic testing we typically do, is the epilepsy genetic panel. Several companies do that, GeneDx, Invitae. Those are the top two that comes to my mind that do these genetic gene panels for. It's called epilepsy gene panels, to look at specific mutations that are known to be associated with epilepsy. If that comes back negative, a lot of times the next thing that I would do is called whole exome sequencing. Alrighty. Think of it as to sequence your entire genome is going to be long and expensive. What's a faster way to look at to sequence your genome? So think of your genome like a sentence, right? If you have a sentence, you have words and spaces. The spaces help us read the sentence faster, right? But the meaning of that sentence is based on the word. And so whole exome sequencing is exactly that. It only sequences the words of your genome, the words that produces proteins that, if it's mutated, can cause a. And so that's a faster way. We get turnaround within 6 to 8 months, 6 to 8 weeks typically. And so that's the kind of, I call it the golden, the best test to do so far. So whole exome sequencing. The reason, a lot of times we don't do that because of price tag and insurance. Alrighty, a lot of times insurances won't pay for that. I know CalOptima doesn't. And it's a little expensive, but there are a lot of centers that do research studies looking at whole exome sequencing for particularly children with difficult to control seizures or intractable epilepsy to better understand, to help with their management. And so a lot of my families have done the research on their own and found research studies and enrolled themselves and got whole exome sequencing done. And so in terms of genetic testing, those are the three main categories there. Chromosomal microarray, epilepsy gene panel, and whole exome sequencing. So those are things you can ask your doctors. Is it appropriate for my child to get any of these testing done? Okay, and that's typically the sequence that we do it in, because that's the sequence that insurance approves it, right? Microarray, panel, then sequencing. Okay. Yeah.
In terms of dysplasia,
Yes.
is there ever a time that's where the seizures are coming from, that you cannot be on the medication, or is that something that's
Okay. So cortical dysplasia is what you're talking about? Okay, cortical dysplasia falls into the category of structural abnormalities. Okay, so when I was talking what are the common etiology or common causes for epilepsy, structural is a big category. Under structural is cortical dysplasia. And what cortical dysplasia means is this area of your brain that has abnormal tissue. Alrighty. In our brain, a little bit of physiology here, anatomy. Our brain is comprised of two tissue. Okay, there's white matter and gray matter. Gray matter is the thinking part of the brain. It's abnormalities in the gray matter causes seizures. Okay, white matter is like a highways. It connects one part of the brain to the other part of the brain to the rest of the body. Okay, when you have abnormalities in the gray matter, that typically is a cause for epilepsy. Cortical dysplasia is where that gray matter is abnormal. Either it's too much, too big, it's not in the right area. Let me try to explain this. It's in the wrong area, which is called wrong area, therefore it can cause seizures, or it's not, the structure of it is not right. It's only supposed to look like a curve, but instead it's a blob, so to speak, okay? And so that's what cortical dysplasia is an abnormal area of gray matter that is a very epileptogenic. It has a very high tendency to cause seizures. And in patients with cortical dysplasia, it'll be hard to be seizure-free because of the very fact that it's an abnormal brain structure. those cells are not normal. And so you'll have a very high likelihood of having to be on meds for a very long time to control seizures. Typically, if you have a cortical dysplasia, and I see a patient with cortical dysplasia, and they fail 2 medication, I'm already thinking about surgery, I'll be honest, okay? And depending on the, how broad or how big the cortical dysplasia is, if it's only isolated to one area, epilepsy surgery can be quite curative, meaning if that's that area of the brain is not doing anything normal. It's not causing normal brain development. It's not causing normal brain neural networking. All it's doing is causing epilepsy networks, okay? So it's just causing problems. And so to remove it takes away the cause. And a lot of patients can be seizure-free after surgery and potentially off medications with surgery, okay? If you have cortical dysplasia, I highly recommend you kind of be an advocate for yourself for surgical evaluation, because even though that area, physically when I look at the MRI, there's that area of abnormality, right? But I don't know, I can't see the networking, okay? The networking is through, the networking I see through seizures, alrighty? And that area of the brain that's abnormal and all it does is causes seizure networking, is gonna spread. Over a period of years, it's gonna tickle the neighbor, and make that neighbor, instead of making normal networking, is going to make seizure networks. And over time, over several years, if it's not controlled, it'll tickle more. And so an area that used to be this big, that causes seizures, that network will grow to be this big. Okay, and therefore, it's very important, that's why we have to emphasize, it's important to control seizures ASAP, because we want to limit that spread. It's called kindling in terms of, when in the medical term, it's kindling. Meaning this area of the brain is irritable, is causing seizures, and it likes to tickle and make more friends. We like to make friends. That area is trying to make more friends to make more seizures, and it's spread its network. And you want normal networks. You don't want to have epileptic networks, right? And so the way to prevent epileptic networks from growing is to control seizures and do whatever it takes to control seizures. And if surgery is an option, I highly recommend that, because the sooner you do it, the better the outcome. Yeah.
How young can a child have for procedure?
We have done surgery at CHOC as young, I think, 6 months, right? 6 to 7 months. And so, honestly, I asked my neurosurgeon to say we can do it at any time, right? A lot of times we kind of weigh the risk of benefits, because with surgery, we want the child to have, there's a lot to go into surgery. We want good nutrition, good weight. And if the kiddo's too small and too young, they may not be able to take that stress of a big surgery like that. And so we can go as young. The youngest we've done is 6 months. I know some centers have gone as young as 2 months too. And so it's a risk-benefit ratio, alrighty? It's always a risk-benefit. If we do surgery, depending on what the seizure burden is, depending on how well-controlled the seizures are, the side effects and response of the medications versus the side effects and the surgical risks, we weigh that and see when is the risk of surgery outweighing the benefits, or should we wait for the child to be a little older, get a little bigger, get some more nice fat tissue on themselves to be a little more nutritional status at a good spot, so that the benefits of surgery outweigh the risks of surgery. And so that's more, I like to think of it as risk-benefit, because if I have a two-month-old baby that's seizing all day long and in status and can't control seizures no matter what I do, but there is a big area of cortical dysplasia there, and I've tried all the meds I know and still can't control seizures, the benefit of surgery at that age will outweigh the risk, because if I don't, there's going to be lots of risks associated with ongoing seizures like that. But if at 2 months the child's having seizures are well controlled, maybe a few seizures a day, but eating and able to gain weight and doing well overall, I might tell the parents, let's see how she does in a month. Let's get her a little bigger, and so before we do surgery. And so it's a risk-benefit, it's a conversation, it's very dynamic, and we constantly are reassessing for that. Okay. Yes.
Our daughter has SB1A mutation.
Yes.
I was curious, do they have any type of gene treatment in regards to that, or is it something that you just have to be aware of?
Did you say gene treatment?
Yeah.
Okay, so SN1A is a particular genetic mutation that has to do with the sodium channel. So it's in the broad category of genetics, genetic causes. It's a mutation in the sodium channels where these patients have intractable epilepsy. And I guess I should define intractable epilepsy. It's when you fail 2 or more medications. You've tried the first med, maximize the dose, and it's still having seizures. You add a second med, maximize the dose, still having seizures. At that point, you have intractable epilepsy. Difficult to control seizures, fail 2 or at least 2 medications, okay? So SCN1A is a mutation in the sodium channel where these patients and these children often have intractable epilepsy. In terms of treatment, your particular question about gene therapy is actually exciting. It's on the horizon. I believe it's not prime time right now, so for me, it's like I can't say yes there is, but it's on the horizon. I just came back from the Child Neurology Society meeting in Charlotte, and there was a talk about gene therapy. Right now, when you think about gene therapy in child neurology, you think of the spinal muscular atrophy, or SMA, Spinraza and Zolgensma, which is a gene therapy for these children. And using that as a template, it's igniting other researchers to use that to see if other gene therapy can be applicable to epilepsy syndromes. And there was this one researcher in Michigan that is proposing that it is possible where we're going to look at the gene and kind of like mirror what Spinraza is doing to treat SCN1A mutation. It's a proof of he was doing a proof of concept. It's still in the lab. It's not prime time. It's not. There's no human trials, clinical trials for it yet. But it is on the horizon, and it's actually going. I think my talk will be my therapy talk for Dravet syndrome is going to be different probably 10, 20 years from now, because I think at that point we'll have what we can offer our SMA patients with at that. So it's on the horizon. And right now what we need is just more what can we do. A lot of times I say it's on the horizon, but I'm like, but what about my patients right now? What about the kid I just diagnosed with Dravet last week here? What about those kiddos? What can we do? Instead of looking at the glass half empty, let's look at it half full. What can we do right now to speed up that process? Is by participating. If there is a clinical trial out there, be brave and participate. I've had some families elect not to participate in clinical trials because they're like, it's okay on other babies, not my child, alrighty. But let's be brave. Let's stand up and participate in these clinical trials so we can move that needle forward faster. And also fundraise for money to support the bright minds that do this research, so they have the finances and the equipment and what's needed for them to move forward this research endeavor. But it is on the horizon. We're very excited about it, and I think it's going to be possible. It's just has a process and procedure to it. Okay? Yeah. It's in the lab. I think it's not even. He is at University of Michigan in Ann Arbor. Yes, that's where he is. It's in his lab. He's proposing it. There's no clinical trials yet. It's not, but if you Google it, you may not even see it quite yet because it's just a talk in terms of this is a potential proof of concept. Okay. But it's exciting because I think it's a template for others to come, like CDKL5, PCDH19, all these other mutations that we know of. Is a step in the right direction. Yeah.
What device do you recommend for keep track when they sleep so that it notifies you that they have seizures?
Okay, so you're talking about seizure detections, right? There's a lot of seizure detections out there. I think you'll see some in the room here. Nothing's perfect. There's no seizure detection devices that's perfect. A lot of times they overcall and they over alert you, and actually causes more concerns. One of my case in point, one of my dad got that. There's an Apple one, right? There's one that's used the Apple phone one. And his son had epilepsy, and he was in a meeting, and his son was golfing. And what do you do when you golf? You swing. And you can swing quite rhythmic too, to the point where it kind of set off the alert. And so he was in a board meeting and he called his son, but his son's golfing, so he wasn't answering his phone. And so he got very anxious. He cut everything short and called the golf in place, and they said, oh, he's just golfing, he's fine. And so it tends to over alert you. And so it's a good safety. There's no one that right now, I don't have anyone that comes to my mind that I recommend for it, because there's not really the best one or a good one or a perfect one that doesn't do anything, but that doesn't do better than a baby monitor. A lot of times I tell my parents, pull out the old baby monitor at night and put it in your child's room. When your child has a seizure, you'll hear it on the baby monitor. And a lot of times that baby monitor does just as good a job, if not better, than the seizure detections devices out there. So I don't have a favorite one to recommend, just because we talk about it a lot at the meeting, at the last meeting at American Epilepsy Society meeting last year, and also at ACNS in the fall, in the summer at DC. We had a talk about the different devices out there. And in the end, it was, when we did a show of hands, what's the best monitor out there, was actually the baby monitor. And so I'd be cautious about spending hundreds of dollars on these things, because they tend to over detect, and it does just as good a job as your baby monitor in your room. Uh-huh.
My daughter is on medication right now.
Uh-huh.
Can she be on medication and keto diet at the same time?
Yeah. Of the 4 different main categories I talked about, meds, dietary, stimulation, and surgery, we can have combinations. And a lot of times most kids are on combination. So when you're on, you can definitely be on med. All my patients on a keto diet are on seizure meds as well. Now, what we do is we try to limit everything, right? So why do we treat seizures? We want to promote good neural development. Yeah, the more seizures you have, the lower your IQ. Alrighty, so we want to promote that cognitive development. And also, but side effects of medication can also impact that as well. And so we try to weigh the risk and benefits and find the right combination for the child so it supports their cognitive development. Yeah. Yeah, focal seizures we call it secondary generalized, where it starts in one area of the brain, and depending on the seizure intensity at that point, it can spread to the entire brain and become generalized. So focal with secondary generalization. So absolutely, yeah. Yeah.
On the kindling you talked about, they have abnormal activity all the time, but then they also have the seizures. Does the kindling occur during that abnormal activity too, or is it just when they have the seizures?
That's a good question. I think the hypothesis is true with both. I think definitely for seizures, but with the interictal, the abnormalities in between seizures, I think that kindling also occurs during that time period too. But not as much as with seizures, because we've had it where if the seizures are controlled, but there's still abnormalities, those networks don't spread as much as the ones that have ongoing seizures. And so I don't know I can't answer that fully, but we know that activity in between seizures can contribute to that, but not to the same degree as the seizures itself. Did you have a question? Yeah. Say that again. Febrile seizures. Oh, petit mal. Okay. Alrighty. So in terms of the question was about post-febrile seizures and its relationship later on with seizures like petit mal and atypical and typical. So let's start with febrile seizures. Okay, febrile seizures is pretty common. 1 in 20 kids have it already, and because during the first 5 years of life, the brain growth is exponential, and therefore certain things like fever can lower the seizure threshold and cause a febrile seizure. Okay. In terms of febrile seizures, not every kid that has a febrile seizure has epilepsy later on in life. There are certain kids that have febrile seizures and are completely fine and lead a normal life. The kids that tend to not have higher risk with a febrile seizure have a higher risk of having seizures later on in life is when they have complex febrile seizures. So febrile seizures comes in 2 categories, right? They're simple and complex. Simple means it's a one-time seizure, it lasts less than 15 minutes, and only one in a 24-hour period. When you have 2 or more seizures in a 24-hour period, or focal signs where only one side of the body is moving, then that's a complex febrile seizure. So if you have complex febrile seizures, you have a higher, I'm a little more worried these children, my antennas go up a little more, that they may have seizures later on in life. But the simple febrile seizures, where one seizure, less than 15 minutes, whole body shaking and jerking, less so. Okay? So in the first, in terms of the risk of febrile seizure for seizures later on, is it simple or complex? So if your child or you know someone with febrile seizures, ask them, is it simple or complex? If it's simple, probably okay. If it's complex, my antenna is a little higher. I actually tend to follow those children in my clinic like once a year. It's to check in. Okay? The other higher risk factors for seizures later on is how many. If you tend to have a lot of them, then you just have a propensity then to have seizures. So I keep a closer eye on those children as well. And number 2 is there's any neurodevelopment or neural abnormalities. Is the kid normal otherwise? If there's any delays of some sort, then I have a little more concern. Okay, so those are the typical risk factors for febrile seizures that make me concerned or not concerned of seizures later on in life. That doesn't contribute much to absence, okay? It's any seizures, absence, generalized, whatever, okay? In terms of absence, there's 2 types of absences. There's typical childhood absence seizures and then atypical absence seizures. Typically, atypical absence seizures are found in children with Lennox-Gastaut syndrome or LGS. Children that have intractable epilepsy tend to have atypical absence seizures. Typical absence seizures typically occur in children, normal children. It's the daydreaming spells, right? Where they're playing, they kind of stare, flirt, and they continue playing. Very short, many times during the day. Typically occur around, the youngest I've seen it is 4 or 5 years old. The oldest is around 12, okay? And so we do an EEG, and there's a classic finding for it. Okay, so the major difference between typical absence and atypical absence is atypical typically found in children with intractable epilepsy, Lennox-Gastaut syndrome. They typically have another seizure type as well. It's not isolated atypical absence. Then typical absence is school-age children, follows a typical time course for it. Does that answer your question? For typical absence, it's actually really good already. I say about 80 to 85% of children outgrow it. The youngest one that I've seen outgrow was 9. The oldest one I saw outgrow is 12. Okay, so around the late childhood, early adolescence period. Okay, so about 80, 85% of them. That leaves 20, 25%, that a small number, about 20% that don't outgrow them. They go on to have difficult to control absences, and they're not able to outgrow them. And so that's the typical outlook for that. Okay. Yep. And yeah. Last question. Yeah. Our goal is no seizures. So if we did it right and we got the area of cortical dysplasia, we should have no seizures. It depends on I guess a better way to answer your question is, depends on where the cortical dysplasia is. Alrighty. If the cortical dysplasia is in the temporal lobe, a good 70-75% chance of seizure freedom of being cured of epilepsy. So it depends on where the cortical dysplasia is. And number 2, we see it on MRI. We don't know what's on the microscope, right? And so a lot of times, based on what our EEG, our MRI, and all the studies that we do as part of the pre-surgical evaluation, we target this area of the brain, we resect that area of the brain. If that cortical dysplasia is actually more broad, but because of the limitations of an MRI, we couldn't see it, that can cause seizures later on in life. And when we have had it where those children, they're seizure-free, but then they have seizure recurrence. We go through the process again. We look under a microscope. There's cortical dysplasia there too. Depending on the circumstances, there's an option. It's an option. It depends on the circumstances. And I believe my time's up. So if you have questions, I'm here. You can come up and ask me. Thank you so much.